our overconsumption of fruit is another factor that is contributing to coronary artery disease and diabetes and fatty liver.
Doc, I need to know, am I a time bomb here? You need to know. You need to know. The stakes are too high. The small, dense LDL predicts coronary disease, not the total LDL. You want to have dysfunctional enzymes, dysfunctional membranes, eat a lot of omega-6. That is why this calories in, calories out nonsense has to go. And people think that heart attacks are caused by progressive narrowing in the artery. Yeah, it gets narrower, and finally, that's totally wrong. Totally wrong.
A lot of you guys asked me to check out Dr. Pradip Jamnadas, who is a cardiologist and has a lot of social media content. So I went over some of it. And as we usually do, I reached out, asked him if he wanted to talk. And Dr. Jamnadas was incredibly gracious, was happy to come on, very generous with his time as well. And we had one of the most productive conversations that I've had on this channel. You're going to see we agree on a lot of things. We had some different views, but we really got into the evidence and we made sense of most of the standing questions. So I hope you enjoy this conversation as much as I did. Here it is. What is visceral fat for someone who's never heard of it? And why does it matter? Why should anyone care?
So we all have fat. We have to have fat because that's how we store energy. The fat is supposed to be stored all over your body. Subcutaneous fat under the skin. The fat that you can grab with your hands is subcutaneous fat. And it's everywhere. It's on your neck, it's in your arms, legs, thighs, butt. And visceral fat, on the other hand, there's a certain type of fat that is limited in amount. It's in your omentum, which is the fat around your intestines. Then you have the fat that's in your liver. We all have some fat in our liver. Then we have some fat that's also around the pancreas. And then we have a little bit of fat around our coronary arteries in our pericardium. Now, visceral fat that we talk about pathologically is when there's excessive amount of it. And when you get excessive amount of it, you will know it because it is deposited mostly in the belly. So when you have a belly that is sticking out, part of metabolic syndrome, I can see a patient who has a large protuberant abdomen where the ratio of the hip to the waist is abnormal. That is abnormal. That fat, which is on the inside, cannot be pinched with your hand. That's visceral fat. Visceral fat is located in your omentum, in your liver, around your pancreas. And now we also realize that it's around your heart. And you can actually see it on certain imaging that we can do that looks at the fat around your coronary arteries. And this type of fat, visceral fat, this is the location, this is the anatomical. And then we can talk about how it's different from your regular fat.
From what I remember, there's some variation, right? Some people just accumulate more fat around the viscera, and even if they look thin, they can still have visceral fat. They just have that propensity, and vice versa. Some people have a large storage capacity subcutaneously, and so even though they might have some gut, they don't have that much visceral fat. I think there's some variation there. Do you have a different experience?
That's correct. When I see these patients, if I can grab the fat, a lot of that is subcutaneous, but a lot of times you can grab the fat, but there's also fat deep on the inside. So in those patients, you got to really look at the overall picture. So we're not just looking at just that fat portion of it. The patient also has high blood pressure. The patient also has a high triglyceride. The patient also has abnormal liver function. The patient also has borderline diabetes, borderline increase in your blood sugars, coronary artery disease, vascular disease. Now I already know that, okay, under those circumstances, any protuberant abdomen has the potential that there's visceral fat in it. And I'm going to find that fat, define it, and get rid of it. Because this visceral fat is pathological, it is inflammatory, and is directly correlated to your future health, especially your vascular health and inflammation. Because it's all to do with inflammation. Everything is inflammation. Getting old is inflammation. Having coronary artery disease, hardening of the arteries, it's all inflammatory. Even dementia, mental disease, it's inflammation. And this fat is a part of the whole overall picture. And we don't want to ignore it. Because if we look back in history, and you look at old pictures of people, they never used to be this way. There's a change today. You look around you walk at the airport and you just look around or walk in a public place and you see these people. And I used to look at them and say, that person has Cushing's syndrome. Oh, this person. No, they don't. This is now the new disease, and it's visceral fat, metabolically ill patients, metabolically deranged patients. These patients have a fatty liver, fatty pancreas, and they have metabolically abnormal physiology. This is the new pathology, which is being ignored. It's being ignored by people. Of course, the media also downplays it. It says, oh, no, you shouldn't be talking about obesity and the shapes of people and protuberant abdomens. For me, it's very pertinent because a lot of my patients come from abroad and a lot of them are South Asians. Now, when you look at them, there's a specific type of phenotype called TOFI. They're thin on the outside, they're fat on the inside. So when you look at them, their arms are nice and thin, the legs are nice and thin. They look great when you look at them facing forward or backwards, but when they turn sideways, the belly is protuberant. And it's very hard to actually grab a lot of the fat. They have visceral fat. It's tight. That's visceral. So we call those TOFIs. Thin on the outside, fat on the inside. And we distinguish those patients from those who are what we call obese patients, but they're metabolically healthy. Those patients have fat also. They're fat all over, just about everywhere. And then ultimately we do blood tests, or I do blood tests to look for inflammation. I do some scanning. I scan for fatty liver and find the pathology. And once we identify the pathology, then we got to say, okay, so why does this patient have a deranged physiology? Why has he got this deadly fat on him, as opposed to the good fat, which is supposed to be a storage, which will be used in the future. Let's turn it over, you put it in, you take it out, that kind of fat. But visceral fat is different.
Yeah, let's get into the causes. Since you segued into it, what are some of the main causes of accumulation of visceral fat and some of the main ways to get rid of it?
The biggest one that I've found is related to prediabetes. So I'm going to give you a little bit of a history on this. As a cardiologist, I was doing angioplasty on all these patients, fixing blocked arteries, doing cardiac catheterizations. And I found that in my earlier part of the career, 30 years ago, a lot of patients would come back again a year, 2 years, 3 years later, and they'd have progressive disease. And I was very disappointed because I fixed that portion of the artery. But when they came back, they had a new blockage further down or in another artery. And I would go back and look at the previous angiograms, and I'd say, he didn't have a blockage there. How come he now has a blockage there? And that gave coronary stenting a bad name. They say, oh, well, I had one stent and I had another stent in 2 years from now. But that's a different story. What happened is that they got new blockage. It was not the failure of the original stent. Now, stents can fail, especially when they were bare metal stents versus drug-coated stents. But the incidence now of stent failure is low. So I was very disappointed to see that patients were coming back. So I did a little study on my own to find out why. And I found that these patients didn't have many other traditional risk factors. They were non-smokers, but I did find that many of them had a protuberant abdomen, they had a fatty liver, and they had insulin levels that were elevated, and the blood sugars were borderline high. So I randomly checked the blood sugars, and I did a glucose tolerance test on about 100 patients, and I found that 60% of the patients had undiagnosed diabetes or prediabetes. That means they had insulin resistance. In those days, we were not measuring insulin levels. All I knew is that they had borderline blood sugars. So what I did is I put them on metformin and I changed their diets, and they got better. The bellies went down and the incidence of recurrent disease stopped. So the relentless progression of disease went down. And then when insulin assays came about, I started looking at insulin levels. And I found that it was the high insulin levels that predates diabetes for many, many years that was actually driving the process. And when I brought that insulin level down through diet and fasting, now the belly went down. So I made a correlation between fatty liver, protuberant abdomen, and insulin. Whenever I found high insulin levels, the patient had visceral fat that was increased. Whenever I found high insulin levels, they were overweight. And the weight was mostly around the belly and around the liver, and they had a fatty liver. Almost every patient who had high insulin levels has a fatty liver on ultrasound or on CT scan. So I made that correlation. So the number one reason that you're going to have visceral fat, which is a deadly fat, which is the inflammatory fat, is going to be hyperinsulinemia. That's the number one cause that I found. The second thing that I found is a more recent event. And the more recent event is I did a deep dive on some patients who did not have high insulin levels, but they had a big fatty liver and they had a lot of visceral fat and they had a protuberant abdomen. I couldn't figure out why until I sat down and did a history with them. And I found that these patients had indigestion, bloating after eating, gas distension after eating, alternating constipation or diarrhea, abdominal discomfort, and they were labeled as having irritable colon syndrome or idiopathic constipation and diarrhea. And they just had gut problems. And that's when I started researching more and more that those patients who have a fatty liver, but they don't have high insulin levels, what's going on with them? And I discovered this thing called metabolic endotoxemia. Now I'm going to explain what metabolic endotoxemia is, because it is a cause of your fatty liver. And that is basically that things that should be in the gut don't stay in the gut. And because they translocate into the bloodstream, your body develops an immunological response against it. So that's the inflammation that you get in your body. But the other thing is that these things have to go to the first place for processing. And the first place of processing of everything that's collected from your intestines or leaks across into the venous system will go to your liver. And in the liver, it causes inflammation and fatty liver. So those who did not have high insulin levels had a fatty liver, had what I call metabolic endotoxemia. Almost all of them I found have symptoms suggestive of a leaky gut. And the symptoms are bloating, gas, distension, constipation, diarrhea, change in stools, never quite having a normal gut. And now we can obviously talk about the reasons for that, because there are reasons as to why you get a leaky gut in the first place. And this term, leaky gut, I took a lot of flack about it because most doctors don't believe it exists. This term was really not very well received by the medical community, but it is real. And there are reasons for it, and we can dive into those. But what I found through practical experience is that when I identify that this is your gut problem, I do what I can to fix the gut. And lo and behold, the fatty liver starts getting better, the weight starts coming down, and inflammatory markers on the blood tests that I do on patients start improving. As a cardiologist, I'm not just improving your blood markers, I'm more interested in your coronary arteries. And I've found, same thing, that the relentless progression of coronary calcification, for example, which is a surrogate for coronary artery disease, flattened out. These patients were not only feeling better, liver's getting better, losing the weight, but the calcium scores kind of stabilized and did not start increasing more. Because I'm ultimately, what's my goal? My goal, I'm a cardiologist. What am I dealing with your gut for? But again, it goes back to my training, because when I was training as a fellow, I was told that, coronary artery disease is due to inflammation. And it's true. The plaque is full of T cells, B cells, macrophages. Who's the enemy? Where is this inflammation coming from? And I was never given a straight answer. Nobody gave me a straight answer. But I can tell you that I have seen the results of treating my patients, fixing their guts, for example, that their inflammatory markers do get better. And these plaques become more stable. So I'm not saying they go away. Calcified plaque can go away. Fatty plaques can go away, and they can actually regress. And low attenuation plaques, which are fatty plaques that are likely to burst, they seem to improve because I can follow that by doing a CT scan. So there are surrogates that are telling me that, hey, you're moving in the right direction. That, the quantity of soft plaque and the low attenuation plaque is getting less and less and less. Calcium doesn't go away. There's no drainer I can give you that gets rid of your coronary calcium. But the rate of progression flattens out. It still goes up, but no more than 10% every 2 years. And that carries a good prognosis. So a lot of my contemporaries think that Dr. J is treating the gut to treat the heart, and he's crazy. But no, it has actually been my personal journey to see the benefits of this. And in the research that I do, I have read, if you take a biopsy of visceral fat, look at it under the microscope, it's full of inflammatory cells. In fact, almost 30% of the weight of that fat is inflammatory molecules. How can we ignore that? Whereas if I did a biopsy of a fat pad from your butt, for example, it will not have that inflammation in it. Visceral fat is physiologically different, anatomically different, immunologically different. And we have so much data now showing that this type of fat, the fat cells, they produce cytokines. They actually transform. They start working in an abnormal fashion and cause the release of these inflammatory molecules. So now you have these fat stores that are actually producing chemicals that are destroying your health. And I couldn't ignore all this. Because of that, now I have to look at gut health on my patients. And then, of course, I looked at the cardiac testing that we do on some patients. Now, I don't have this particular software in my office, but we do CT scans, coronary CT scans, and we look at fractional flow reserve, soft plaque. But there's another test that actually looks at what is the fat that's around your coronary arteries. Does that have any characteristics that are different in sick patients who are inflamed versus those who are healthy? And we find that there are characteristics, attenuation factors, as we call them, that tells us that that fat, the more inflamed it is, the lower the attenuation of the fat around the coronary arteries, the higher the inflammatory markers and the higher the risk of that patient to have an event. What I mean by an event is plaque rupture. Look, if you have progressive atherosclerosis, narrowing of the artery, I can fix it. Positive stress test, it's this lack of circulation, I'll put a stent in there or I'll bypass you. But if you have the unpredictable rupture of a plaque, which is the equivalent of having a pimple suddenly rupture inside your artery and a blood clot forms on it, I can't predict that. But what will predict that is if you have inflammation in your body. That is why we got to hunt down inflammation and get rid of it, because the unpredictability in coronary artery disease is that sudden heart attack. And people think that heart attacks are caused by progressive narrowing in the artery. Yeah, it gets narrow, and finally, that's totally wrong. Totally wrong. Heart attacks are not caused by that. Heart attacks are caused by the sudden breakage of that plaque, especially at the junction of the hard plaque and the soft plaque, where it bursts open and then a blood clot forms on it. Heart attacks are caused by blood clots, but the cause of the blood clot is originally the rupture. That's totally unpredictable. So a patient may come to me and unpredictably get a heart attack in 6 months and say, but doctor, you just passed my stress test. I said, yes, I did. You had a normal stress test. You did great. Then how did he have a heart attack in 6 months? Because most plaques that crack and cause heart attacks are actually not flow limiting plaques, which means that they are less than 70% blocked. So where's the unpredictability? How did he go from 50 to 100? It's the rupture. What caused the rupture? Inflammation. What caused the inflammation? So you keep going backwards. Peel the onion. What caused the inflammation? Well, you better find out. There are a lot of causes for inflammation, but the ones that we have already talked about, hyperinsulinemia is a very important one, sugar diabetes, glycation of your proteins and molecules in your body caused by the diabetes. So all that is one thing. Metabolic endotoxemia, which is the translocation of molecules which should have stayed in the gut, but they got in. And the biggest one I'm concerned about is lipopolysaccharides. So I'm going to just tell you about LPS. You probably already know about LPS. LPS stands for lipopolysaccharides. Lipopolysaccharides are bacterial wall products. So it's the wall of the bacteria. So when the bacteria in the gut die, there's lots of LPS in the gut, inside the gut. The gut lining is so good that it actually prevents that from coming into your body and keeps all the bacteria, 100 trillion of them in your gut, staying in your gut, and only allows food that has been digested to come through. So it's a very tough area to be in. And your entire immune system, 80% of it is in your gut. And there's a handshake between the bacteria in your gut and your immune system. Now, LPS is getting through. So we'll talk about the pathology that allows it to come through. But when LPS gets through, now LPS is a bacterial wall product. And your immune system looks at it and says, whoa, this stuff shouldn't be in my bloodstream, and starts reacting against it. So it mounts an immune response, and the immune response starts right there in the gut. So you start producing inflammatory molecules, of course, activated immune system. And more importantly, I want to bring in the concept of good cholesterol, bad cholesterol, and the really bad one, which is small dense LDL. Because when the LPS gets into the bloodstream, I have seen and read that the LPS is not only taken up by the macrophages or by the cells of your body, your immune system, but it's also affecting your LDL. Now, you've opened a can of worms here, right here, because in ancient evolution, your LDL molecules are actually part of the immune system. And they take up that LPS. And when they take up that LPS, now you have these lipids carrying with them this foreign molecule called LPS. Now this combination becomes the target of your immune system. So when your macrophages sees that, it gobbles it up. And when enough of that bad, small, dense LDL is in it, you get a foam cell. Some of this LDL that is small and dense as a result of carrying this passenger, the LPS, because of that, it gets oxidized in the lung, goes out into the arterial circulation. When it gets into the arterial circulation, the first place it's going to meet is the coronary arteries. And there it causes the oxidized LDL, damages your lining of your coronary arteries. So there's a glycocalyx, which is lining your arteries in your heart, in your coronaries. And that gets damaged, exposing the endothelium. The endothelium now gets activated. And by I mean activated, it starts expressing adhesion molecules, which are like Velcro. And these macrophages come along laden with that bad LDL, the small dense LDL, attach themselves to the endothelium and eventually get inside and get endothelialized. So this process of atherogenesis started because you have molecules that should have not got into the bloodstream. And as a practitioner, I've seen that the higher the amount of LPS in my patients, I see that they have more soft plaque, low attenuation plaque, more progression of plaque, more development of coronary disease in the future. And the small dense LDL predicts coronary disease, not the total LDL. So total LDL is important. Don't get me wrong. I'm not saying it's not, because the hazard ratio for LDL is 1.29 for coronary disease or heart disease. But the hazard ratio for triglycerides is 1.8. So triglycerides are actually far more important in predicting who's going to get actual coronary artery disease. But the point is, it's not just the LDL. What's most predictive of who's going to get coronary disease is small, dense LDL, damaged LDL. And your body is trying to get rid of damaged LDL. So I do measure the damaged LDL in all these patients. And there's a direct correlation between visceral fat, fat in your liver, LPS, which comes from the leaky gut, coronary artery disease, inflammatory markers that I measure on the blood as well. So it's really weird that this whole circle of disease is coming from a place that was not suspicious, never thought. But we know from history that certain interventions help the heart. Fiber. I've always been told fiber is very good for you. And I know why now, because it feeds the good bacteria. But coming back to the pathology here of what's actually causing this coronary artery disease and how visceral fat happens. Visceral fat tells you that you have an abnormal pathology going on. Now, there's one more thing I want to say about the fatty liver, which is regular toxins. For example, alcohol is a toxin, but there are a lot of other toxins in the body that can also evoke an inflammatory response. Now, this is an area that I'm just getting into, where I'm finding a correlation between those patients who have the highest levels of toxins in the body and coronary artery disease, inflammation, and inflammatory markers. So again, it ties in with my view that if it's immunological, if your coronary artery disease is an immunological problem, then we need to chase the immunology of the body. Immunology means you're reacting to something. What are you reacting to? Damaged LDL, glycated molecules. So these glycated abnormal molecules from high blood sugar. The body wants to get rid of these. They can't work properly. And they contribute to this inflammation. And then toxins. Toxins also contribute to the inflammatory substrate that's causing all this problem. So it gets a little complicated, but looking for toxins has now become a major part of my practice, where I do, okay, if the patient wants to know, doc, what can I do to stop this relentless progression of disease? And okay, I passed my stress test, got my stent done, I got my bypass done. Now, where do I go next? Number one, do you have a fatty liver? Number two, how much visceral fat do you have? And I'll screen for that. What are your inflammatory markers? Tell me all about your gut. Tell me about your exposure to toxins. Tell me if you have mold or heavy metals in your body. They seem to tie into all this inflammatory process. And then I can measure your LPS, not only in your stools, but I can measure it in your blood as well. I can look for inflammatory markers that are telling me that you are full of inflammation. Then, of course, comes the therapy. How do I get rid of that inflammation? Well, you got to find the source first and then go after the source. And most of the time, it means you need to fix your diet. That's why I'm so big on fat. Okay. Let me backtrack a little bit about what happened to me. Because you see, it's been a whirlwind of experience. And I'm so grateful that I was able to participate in this metamorphosis. Because what happened is that I realized that fasting is very helpful. and I made videos on fasting. And you already probably know about my fasting background. But I often wondered, why would fasting have such a profound effect on health? Because I was telling patients to fast because I want them to lose some weight. They would come back and tell me, Doc, I feel great. I said, of course, you lost some weight. No, Doc. I'm thinking better. I have more energy in my head, not just physical energy. I have more energy in my head. I wake up with more energy. I don't have mental fog anymore. My depression is better. My anxiety is better. Oh my goodness, this is all psychological. But no, there's real physiological basis for all this. So when they were fasting, I look at the inflammatory markers and they're all coming down. And I look at the visceral fat and it's shrinking, because when you start fasting, that's the fat that gets mobilized first. You don't start losing fat around your neck only. No, you start losing the fat in the viscera. The weight. They'd come back to me 2 months later, say, Doc, I'm 2 belts smaller than I was, 2 inches less than I was before. And it's just I was saying, wait. Only your waist went down? Only the viscera went down, the visceral fat? Sure enough, there it was. So fasting seemed to help that. Fasting was helping the skin. I said, wait. Don't. Oh yeah, Doc, my psoriasis got better. My joint pains got better. My joints. I'm not waking up with joint pains. My hands feel better. I used to get all these joint pains. So if I'm going to tell you to fast, I better know everything about fasting. So I started reading more and more. And now I know that fasting has such profound effects on so many different variables in your health, whether it's your stem cell mobilization or brain-derived neurotropic factor or anti-inflammatory effects that it has on your blood, or changes in your gut microbiome and the amount of liquidus of your gut, or whether it's just reducing the amount of fat in your liver. That in itself is anti-inflammatory. So it's been an incredible journey to see how fasting alone had such a profound effect. And of course, cutting out sugars and carbs and all that ties in. Because you want to get high insulin, eat a lot of carbs and sugar and eat it frequently. So insulin level stays really high. Nice way to get a nice fatty liver. You're going to get a nice big belly. You want to get rid of the belly? Cut out the sugar, cut out the carbs, and stop eating so frequently. So insulin levels come down. That means you got to do some fasting. And of course, we can define what fasting is all about, but bringing common sense into life. Who told you to eat every 3 hours? Who said that? How did this become the norm to have 3 meals and 2 snacks? And the composition of the food and all that. So bringing back some normality to the frequency of eating and what you're eating, getting rid of all processed foods, suddenly changed visceral fat, suddenly changed inflammation, weight, insulin levels, and all these other benefits, which I never expected my cardiac patients to have. I never thought they'd come back and thank me that the depression's better. I said, look, I'm not a psychiatrist, okay? I'm just a cardiologist. But the effects are profound. And it all comes back to what you started talking about a few minutes ago, saying visceral fat, because visceral fat is one of the mechanisms, one of the factors that happens. And just look around you, people are inflamed. They have all these big bellies. And I'm not saying that aesthetically. I'm saying this from the medical standpoint. This is a medical problem. This is not an aesthetic problem. This is a medical problem. Let's not turn a blind eye to it. Get your head out of the sand. That if you have visceral fat, you need to do something about it. You need to at least get it checked out. Doc, I need to know. Am I a time bomb here? You need to know. The stakes are too high. And it affects not only coronary artery disease, it affects dementia, mood, depression, sleep, and even some cancers. because we know that patients who have a fatty liver and obesity also have a higher incidence of certain types of cancer. So backtracking it, okay, visceral fat is easy for me to measure. Let's use that as one of the parameters. Let's look at blood tests, use that as a parameter. Let's look at your gut health, use that as a parameter, and backtrack to get you better. So, I've been talking about this now for the last 10 minutes and didn't give you a chance to say anything, but you can see how excited I get about talking about visceral fat. That visceral fat is really a problem. And when I look at the histological specimens of visceral fat, they're so different from regular fat. When I look at a fatty liver, oh, by the way, when I look at a fatty liver, what do I see in the fatty liver? So I thought I'll just find a lot of fat. That's not true. When you do a liver biopsy, the Kupffer cells, those are macrophages of the liver, they're all over the place. So what are you doing here? What are you doing there? They're trying to evoke an immunological response against something, because that's their job. They're part of the immune system. What is it that you're after? What are you guys hunting here? What they're hunting is stuff that got into the liver from your gut that shouldn't have got in. They got in through the gut. So what's wrong with the gut? It's allowing things to get through. Why is it allowing to get through? Bad food, bad bacteria in your gut, toxins in your gut. Big problem. And look at food sensitivities. So intact food particles are not supposed to get into your bloodstream and evoke a response against them. But I'm finding that people are just allergic to everything these days. And it's because they have a porosity, a permeability problem. I never used to be allergic to this. I am now. Well, doesn't that tell you something? It tells you that there's a problem. Your immune system is being exposed to something which it never was exposed to before. So the field is still evolving. I am evolving. But I think that the more I look into it, it all comes down to your immunological responses, and they are abnormal because we're doing something wrong. Now, there are other factors also, but coming to visceral fat alone, these are the main factors that I really look at. And toxins are huge problem I'm finding. And these toxins are not, look, I want to say something about toxins very quickly, because it's not just toxins like alcohol that goes and kills all your bacteria and then kills your liver. No, I'm talking about things that should not be in your body. The body has not seen certain chemicals, but today's environment is full of chemicals that your genome, your human physiology has never seen in its entire evolution. It took Mother Nature billions of years to come to this physiology. And now we introduce new chemicals into it, whether they are pesticides or herbicides or plastics or forever chemicals or flame retardants, or whether we're introducing metals into our body. We have to have the humility to understand that this is not normal to have this exposure to my body and my physiology. And if I'm going to wait for double-blind placebo studies that are done over the next 30 years, it's too late. It will be too late. And I think that when it comes to toxins, I just have a double dose of common sense that, look, just get rid of the plastics, get rid of the herbicides, get rid of all these pesticides, and get rid of the heavy metals, and try to improve your gut microbiome, because that helps you to detoxify and help your liver, your fatty liver, get rid of it, because then your liver will be able to detoxify all these toxins, because the detoxification center is the liver, which you've already compromised because you developed a fatty liver because you ate too many sugars and carbs. You see the compounding problem? The compounding problem I'm seeing out of practical experience is that a patient starts out with a fatty liver because of his dietary habits, then develops toxicity about 5-6 years later. I'm like, how did this happen? Well, your liver is supposed to be detoxifying you, but because of your fatty ectopic visceral fat, your ability to detoxify has been limited. So what I do is I get rid of the fatty liver, obviously, in the best ways that I can, but then I give them supplements that improve your liver function. And that allows you to detoxify faster and better, and improve your microbiome. Because if you improve the microbiome, it's the microbiome that actually binds a lot of these toxins and takes them out in the stools as well. So the problems are compounding each other. You develop a fatty liver, now you're more prone to toxicity as well. And that just makes your whole immune system go crazy even more. And whether it's mold, mold is another one that I've seen quite a bit of. And you know, I never believed that mold could be such a problem, but I have seen in the toxicology a lot of mold in a lot of the patients. And it may not be directly related to coronary artery disease. I'm not sure because I don't have that data yet. But it certainly causes inflammation. I know mold causes inflammation because I see the markers, and when the mold gets better, the markers get better. So, and I know that mentally, a lot of the problems that patients have, whether it's fatigue, tiredness, excessive sleepiness, anxiety, I'm finding that it's toxicity with mold as well. So it all comes down to, again, the mold getting stuck in your body, in your gut or in your sinuses, or repeated exposure to mold. So sometimes even when they're out of that environment, they can still have mold. But the bottom line, what we're trying to say here is that, look, visceral fat is a sign of something major having gone wrong. And it's being ignored. It's ignored by everybody, including the medical profession. Oh, you just got a little bit of fatty liver. Almost 50% of the population now has a fatty liver. Now, that's not normal. Why have we normalized a pathology? You should not have a fatty liver. You should have a nice, good liver, because your liver was supposed to be like that for multiple reasons. It's supposed to detoxify you. It's supposed to be the center of your metabolism. It's one of the most important organs in your body. And visceral fat should not be there because it releases all these inflammatory molecules, especially around your pancreas, and it's just going to make things worse. Your omentum, same thing. So I think you hit a nerve with me there when you started talking about visceral fat. And
yeah, no, a lot of super interesting points, and I'm hoping that we can touch on a couple of those. I'm hoping we can touch more on the small dense LDL and the a lot of the different ideas that you brought up. With regards to visceral fat, one thing that I thought was really interesting when I started looking into this, and I think that a lot of these things, the relationship between visceral fat and causing insulin resistance, causing inflammation, causing hyperinsulinemia. I think I've seen a lot of evidence to back that up. I think that's well supported. When I started looking for ways to fix visceral fat, and I was looking at, is there a diet that's better? Is there a different approach that's better? And I was going through this, I found some really interesting experiments where they put people on different diets and they try to control for everything else. They try to control for calories and all this. And this goes back to the point that you were making that it's about eating carbs, and then that causes your insulin to go up all the time, and eating all these carbs throughout the day causes your visceral fat to go up. So one very interesting study that I've seen randomly split people into a carbier diet and a much less carby diet, but the calories were matched. Both were effective to reduce visceral fat, and they look identical. Both the visceral fat comes down and stays flat for the rest of the trial. So that to me was saying that there's multiple ways to reverse visceral fat. And that to me, this is good news that people with different preferences that do better on different diets can get the benefit of reducing visceral fat, which is crucial. Just curious about your thoughts on that.
Yeah, no, absolutely right. So what was it? The calories were the same, but it was the constitution of the food, the makeup of the food. That is why this calories in, calories out nonsense has to go. A calorie is not a calorie anymore. If we know that, the body deals with it differently. It's how the body dealt with the high carb diet and the high sugar diet. It caused all that metabolic changes. And when you cut down on the carbs, so you were on a very low carb, low sugar diet, it produced fat loss when the calories were still the same. And in that study, I'm not exactly sure how we defined low carb versus mild amount of carbs. All I know is that when carbs go down, you're going to get reduction in fat. That is why in both the groups, you had fat reduction in the visceral fat. You just have to cut down on carbs. That's it. Now, I'm not saying that you have to be on zero carb, but this is very pathological. So in that particular study, I'm not exactly sure how much carbohydrates there were and what the composition of the diet was. But yes, it shows you that a moderate reduction in carbs versus a significant reduction in carbs and sugar both resulted in reduction in the visceral fat, even though they were getting 2,000 calories in. So in my patients, for example, who eat very high calorie diet because they eat a lot of food because they're bodybuilders and they're doing other things as well, I find the same thing, that it's the composition of the food that actually reduces your visceral fat. Mm-hmm. Very important. And also, it's not just only the insulin, the metabolic effects that the low carb diet is having. Low carb affects your hormones. Yes. It affects your insulin. Yes. But it also has other effects. It also changes your microbiome, because the bad obesogenic microbiome loves sugar. So when you cut down on simple carbs, you're also changing other things. You're not just changing your hormones, which affects your liver. You're also changing your gut microbiome. And these patients will tell you the guts feel different. I stayed away from carbs, or I'm eating much less carbs. I get less bloating, less abdominal discomfort after eating. So the microbiome itself also, and when the microbiome changes, that also changes a lot of things for you, because the microbiome will affect your intestinal permeability. The microbiome also releases postbiotics, which have anti-inflammatory effects in the body. We know that the good microbiome will release a lot of butyrate, for example, short-chain fatty acids. So there's a composition of your bowel microbiome that changes on the carb diet, the low-carb diet. And we need to look into that more and study that more, instead of just looking at carbs, sugar, and insulin and glucose, which is what we've done all along. And that's where we started. That's where I started. But now I also say, okay, whatever I'm doing, what else is it affecting? It's affecting my intestines. It's affecting my gut as well. It's affecting my bacteria as well.
Mm-hmm. Maybe it's helpful to introduce the concept of carb quality, because a lot of times when we say carbs, people don't know if we're talking about lollipops or steel cut oats or like these widely different foods, right? So just to clarify, that study that I was mentioning.
So good. You are so good. You are so good, because you hit right on it. So let me elaborate on that. So the ones that are the bad carbs, or so-called bad carbs, is it the carb that's bad? Or is it that they don't have the company that they should have, which is basically fiber? So the bad carbs are basically the ones that are processed. Those are simplified. They've been purified. They've been altered by man. And taken out of them is all the fiber. So now you can have the same carbs with a lot of fiber versus the same carbs in its isolation, in a very unnatural state. Today, all processed foods are without any fiber. Now the fiber, so what's that got to do with everything? Well, the glycemic index of that food changes with the fiber. So the rate of absorption of the blood glucose is affected, and therefore your insulin production is going to be changed. Same carbs, but with lots of fiber. So the fiber forms like a mesh network in your duodenum, and there's less stimulation of insulin. Plus, absorption is different. Further down, it slowly gets absorbed, the carbs, so it doesn't cause that massive spike in your blood sugar. So, and the fiber has other effects. So now, again, moving away from the metabolic effects, you say, what else is this fiber doing to your body besides just attenuating your insulin and glucose response? Is my fiber doing something else to me? Non-processed foods or foods that have more fiber in it. And then says, yes. What is it? Well, that fiber goes down. You can't deal with it. I can't deal with it. I can't digest it, but my bacteria can. So now all of a sudden you've changed your gut microbiome. Again, you see, it's coming down to the microbiome again. So microbiome's changed, and now that microbiome changed for the benefit of you, because when you eat fiber, the keystone species, which are the good ones, the beneficial ones for you, they flourish. And when they flourish, they're going to produce what is known as postbiotics. Postbiotics are chemicals that the bacteria produce and get released into your bloodstream. And I already mentioned short-chain fatty acids, but there's a whole bunch of others as well. In fact, they estimate that 30 to 40% of the micronutrients in our body are actually postbiotic. They're products of bacterial metabolism in the gut. So eating high carb diet in and of itself means that you're going to be on too much pure refined carbohydrates. So the question is refined food. There's nothing fine about a refined food. So you can eat carbs, complex carbs that come naturally with the fiber built into it. I have no problem with that. I have absolutely no problem with that, because I know that the endocrinological effects are going to be different, which is the metabolic effects are going to be different. And then the microbiome effects are going to be different. Eat carbs, but you got to eat complex. Define your carbs. So you're absolutely right. It's not just saying low carb diet and low carb this and that. And that's trying to simplify too much. Look, go back to nature. Nature packages everything together most of the time. It comes with the fiber as well. For example, I eat raspberries, I eat blueberries, and I eat one strawberry, and I put all that in my kefir every day. And I know there's some sugar in it, but the nice thing is that they come with all that fiber, and raspberries are full of fiber. So are my blueberries, and I also sprinkle it with some inulin with FOS. That's a soluble fiber that I put into it, and I mix it up together. So now I am getting my carbs. Yes, I'm getting my sugar. Yes, but they're packaging it in a natural state with what nature made with the fiber. So define your carbs. Now, there's another thing about carbs that I want to mention, which is sometimes what my patients ask me about. Oh, I'll have to eat my rice because, that's my staple diet. Of course, all the patients from South Asia come to me with the rice diet. Asia comes to me, even Mexicans come to me. And I say, yes, go ahead. But what you got to do is you got to cook your rice, cool it, let it cool off completely, then put it in the refrigerator, eat it the next day, heat it. So you're creating some more resistant starch. And the resistant starch, now you'll produce a less of a sugar effect, the insulin effect, and it'll go down into your gut. And who's going to eat it? Your bacteria. And they're going to benefit you in return by giving you postbiotics. So your definition of low carb diet has to be refined even more by saying what? Non-refined, natural, whole foods in its intact form. Don't take things out, because nature built it in. So I think your nuance on that is excellent. I love that.
I'm glad we clarified that. I think people are going to find that very helpful, because just to clarify real quick, that comparison that I was referring to, I think it was about a twofold difference in carb intake between both groups. One was less carbs and the other one was more carbs. But matched for calories, and they both were effective in reducing visceral fat by the same margin. They looked identical. They both were very effective. But exactly as you're pointing out, the high carb group, it was whole carbs. It was oatmeal. It was fruit. It wasn't lollipops and soda and stuff like that. If we had a group with a lot of refined carbs, I would expect the results to not be as positive as those two were. So
absolutely.
I think that makes a lot of sense.
Oh, you're absolutely right. Look, what are my golden rules on carbs? If it comes in a box packet, it's got a barcode on it, made in a factory, don't even bring it into the house. Do not give it to your kids. Don't eat it yourself. Anything that's processed, ready-made, ready to go in a packet, just get rid of it. You don't need it. That's not food. That's a product. Okay, so are we going to be a society that's going to live on products? No. You live on products, you're going to get a visceral fat. You eat real food, and you're going to be much healthier. Real food. You got to eat real food. So coming down to your carb thing, it's all about eating real food. Real food for who? Who are you eating for? I've discovered that I'm not eating for myself. I'm eating for me and my bacteria. So the bacteria want fiber.
That's a good way to look at it. We're feeding the bacteria. Some of the foods are not feeding us directly, but indirectly through the bacteria. Yeah.
Yeah. And I think that this is an insight that is very helpful. Every time I'm sitting down to say, what am I eating this? Okay, I'm eating this for me, this for my bacteria. And I think when people do that, they're going to make better choices. They're going to make natural choices. And that's what I want my patients to love their food, but eat real food, not processed foods. And take for example your vegetable oils. Everything's processed. That's a processed oil. The vegetable seed oils, they're all processed. So when we do experiments and try to take tissues and try to make it malignant, which means make it become a cancerous growth, right? What were we putting on top of it? We were putting omega-6. We were putting vegetable seed oils when we were doing research in animal studies and whatnot. So why are we eating it? And we know that this is not going to be good for us. And there's so many studies, which of course, we can, in the future, we can talk about vegetable seed oils, but this is one of another big culprit. So we've got this processed foods, high and simple carbs, and then vegetable seed oils to top it off. And I think that has a big problem, because I've seen that my patients who continue to consume vegetable seed oils have small, dense LDL particles. And in the beginning, let's not forget, these are LDL particles. They should be large and fluffy. They become small and dense as a result of, I'll just tell you briefly, there are 5 major things that I've found that seem to be doing this in my patients. Number 1 is glycation of the LDL molecule. That means having high sugars. Your A1C is high, your blood sugar is high, then you're going to get small dense LDL. Number 2 is omega-6, eating a diet full of omega-6. Because the omega-6 will go into the LDL particle and displace some of that cholesterol, replace it, and then that omega-6 undergoes what is known as lipid oxidation or lipid peroxidation. When you get that LDL molecule that is carrying omega-6, it's going to very easily get oxidized. Normal, healthy LDL particles don't get oxidized that much. It's your oxidized LDL. What makes it oxidized is it's carrying a lipid on it. It's getting lipid peroxidation. In fact, every cell in your body, the cell membranes have fats. And when you eat too much omega-6, vegetable seed oils, all your cells are replacing the fat in the plasmalemma of your blood, of your cell membranes, and it affects your function, because the cell membranes is what controls what comes in and what goes out, and you get dysfunction. All those receptors are in the membranes, and they get dysfunctional. You want to have dysfunctional enzymes, dysfunctional membranes. Eat a lot of omega-6. And you'll see the effects of that. Another one is what I call advanced glycation end products. This is it's such a big word and everything else, but basically, if you take food, I told you got to eat real food, right? You don't eat processed foods and refined foods and all the stuff that's made in factories and everything by man. So what if we take good food, but we kill it by overcooking it, blackening it, frying it, subjecting it to unnatural, extreme high temperatures? You're going to get the combination of glucose, protein, and fat. And when these molecules at high temperatures combine together, that is known as advanced glycation end products. These are one of the causes of advanced glycation end products. These molecules, when they get into your bloodstream, they're not supposed to be there. That's a very unnatural food to consume in large quantities with these molecules, and they cause inflammation. And we have receptors against these. They take them out of the circulation. They call RAGEs, but they get overwhelmed. And then I find that these patients have small, dense LDL particles. And when I tell them to look, start steaming your food, start cooking it at the highest temperature of water, start lightly cooking your food, and don't eat barbecued food every day and blackened foods every day. And I find that the LDL particles sizes get better. They go from pattern B to pattern A as well. And then the other thing that I've seen that causes small dense LDL particles is a leaky gut, the metabolic endotoxemia, which we talked about before. that also causes it. And one last one is generalized toxins, that I find that even the toxicity scores are really high, they have small dense LDL particles. Yeah. So small dense LDL particles in traditional cardiology have been associated mostly with insulin resistance, that if you have a high triglyceride and a low HDL, then you likely have small dense LDL. And that makes perfect sense too. So there you go. So I talk about the lifestyle changes that people have to do, not only in terms of what they're going to eat, but how you're handling your food. Let's not destroy the food and then consume it. We need to eat foods in a state that nature presented it to us. So we want to eat good food, real food, don't kill it. And eat a variety of whole foods. And when I eat a variety, it's of course good for me to eat a variety, because then I'm not going to have these metabolic problems. But I'm also eating a variety for my bacteria. See, it comes down to the bacteria as well, because we talk about all these polyphenols, for example. Did you know that we don't actually metabolize most of those polyphenols? They're metabolized by your bacteria. And the more of those that you eat, the different colors, foods, and the polyphenol, the better your microbiome develops. And your microbiome, whose total genome is about 4 million genes compared to your meager 23,000 genes at most, tells you that the capacity to digest food and assimilate food and metabolize foods is controlled more by your bacteria than by you. You have 18 enzymes that digest food. We have 4 million bacterial gene products that can accommodate all sorts of different foods that you eat in your gut. That is why when you put artificial sweeteners in your body, for example, it's not good for you, because one of the reasons that I complain about that is because it changes your microbiome. So it's a huge problem. So again, who needs artificial chemicals in your body? You don't need it. You don't need it. So you'll get a fatty liver, you'll get visceral fat, inflammation. Simple fact. And we need to say now. So again, coming back to all that, if you do fasting, that solves so many different things. And that's why I like fasting so much, because you talked about the different diets. So let's say I have a not so good diet, but I have fasted all day long, and then I eat that meal. The body is far more forgiving in its chemistry and its buildup of toxic materials in your body than had I eaten that same meal and having just had lunch. So what am I saying? What am I saying is that when you eat a meal that's not that great for you, but you're eating it infrequently, especially on a fasting state, the body is far more forgiving. Its rise is going to be different. The whole metabolic, because you're eating it in a fasting. We should be, look, it's common sense. We should be eating in a fasted state. If you're not in a fasted state, why are you eating? It'll cause all this abnormal chemistry. You should eat in a fasting state. Then you got to define what a fasting state is. So a fasting state is anything more than 12 hours. So now you have different types of fasting. 12 hours, 18 hours, 24 hours, or even prolonged fasting, which really changes your metabolism and resets you. So that's a whole topic of different discussion. But those who have the worst visceral fat, they need to do prolonged fasting. So if you make dietary changes, you find that the visceral fat went down. Now you kind of plateaued. You need to do a 3-day water fast or a 5-day water fast, because that will just jumpstart your metabolism, get that insulin sensitivity to come right down. Your gut microbiome resets, and now you'll start losing weight again. So visceral fat goes down not only when you change the composition of your food, but how often you eat and fasting. Fasting is phenomenal to get rid of visceral fat. Yeah.
Yeah, no, really, a lot of interesting points again. Let's talk a little bit about seed oils, because you brought it up. I think it's an interesting thing to talk about. I've done a lot of content about it. I've tried to investigate a lot of these questions that people ask and go over the evidence systematically. I found that people have very strong beliefs about seed oils, but I've been surprised often looking at actual scientific evidence on seed oils. So we probably won't have time to touch on everything, but you touched on seed oils and cancer. I have looked into it. I have not found a relationship between increased intake of seed oils or omega-6s and higher incidence of cancer. When we look at cancer mortality, for example, there's a study that looked at 500,000 people followed over, I believe it was 16 years. And people who cooked with canola or corn instead of butter had lower cancer mortality compared to those who cooked with butter. And this was adjusting for the usual confounders, things like BMI, smoking, exercise, other food components. So I have not found a body of human evidence pointing to higher risk of cancer with seed oils. I'm open to it, but I'm curious if you've seen evidence of this.
I haven't seen it in human studies, but I have seen that in the lab we can create those changes, but that doesn't translate to increased cancer rates in human beings due to omega-6 intake in the form of seed oils. Seed oils do have, some of them have this gas that they use in the processing. I think it's called hexane. And there's a lot of that in there, and that is carcinogenic. But I have not actually seen in human studies, as you rightly pointed out, that. Now, when we look at visceral fat in South Asians, because South Asians have tofu, and I look at the diet, and I say, okay, what is it that's giving these people insulin resistance visceral fat in South Asians? Because South Asians have some of the highest incidence of tofu, thin on the outside, fat on the inside, and they have a high degree of coronary artery disease. And they're not terribly obese. The body mass index is usually pretty normal. And when we tease down the dietary changes they've made, it's because they have started consuming a lot of vegetable seed oils. And I've seen that. So South Asians tend to eat too much carbs. No doubt about it. They eat too much carbs. Number two is that vegetable seed oils. And you're right. It's hard to tease all these things out in a dietary study. It is hard to do that. So you're right that the whole team is split right now on vegetable seed oils. I'm swaying a little bit on this side because it is ultimately processed. And I don't like anything that's so processed. I want to try to, and I'm not going to wait another 30 years to show me that, yes, you're right about the vegetable seed oils. So I just get rid of them now. So my advice to most of my patients is not to eat excessive amounts of vegetable seed oils, to try to minimize that as much as possible. So,
and what do you recommend instead?
So in butter in small amounts, I have no problem with butter in small amounts. And I've found that my patients who actually eat butter, their particle sizes, you'd think that, oh my God, this is so bad for them. The LDL is going to go up. Yes, it goes up just a little bit, but the particle sizes actually become larger and the pattern goes from B to A. So I'm not too concerned about it. So I do tell them to eat a little bit of butter. South Asians, I tell them to eat a little bit of ghee. So cook with a little bit of ghee, not large amounts, small amounts of ghee, and a little bit of coconut oil as well. And the coconut oil has to be extra refined coconut oil. And that's the oil that,
yeah, really interesting, because I have questions about this specifically. So I think one thing that might be a confounder here is that when people switch fats, but they also lose weight overall, because they're fasting, they're cutting ultra processed foods, the weight loss is going to have some effect on the lipoproteins as well. So it's hard to know in a patient, it's hard to know exactly which of the many changes is causing the specific observation. We have a lot of comparisons between seed oils and butter and ghee, direct comparisons in randomized trials, looking at visceral fat, looking at liver fat. In every trial that I can remember, the seed oils beat butter, coconut oil, or ghee for liver fat, for visceral fat. And this is matching calories again. In general, the seed oils, we tend to see a reduction in liver fat, varying degrees depending on everything else. And with saturated fat in general, either stays the same or goes up. The liver fat deteriorates, increases. Now, this is, of course, dependent on overall. If the person is losing a lot of weight and eating more butter, then I would expect that to trump the effect of butter. But just the fats by themselves, this is consistent in randomized trials that I've seen. I don't know if you've seen anything going in the opposite direction or not.
Yeah, I've seen some of those studies. I wasn't too convinced. Um, I think that basically I look at my cardiology studies that came out in the past, where we took patients and we took away the saturated fats and substituted them with vegetable seed oils, and the LDLs came down, but they had a higher mortality rate. So those are like in the Minnesota study, and then there's a subsequent one as well. And I just think that lowering the LDL definitely happened.
Mm-hmm.
And the group that had saturated fat had higher, but the outcomes were different. So, in my cardiology studies, I have found that it's not just the total LDL I'm concerned with. I'm looking at visceral fat. I'll do some deeper dive into those studies to see if there's real correlation or not, and what is the mechanism, because there may be other compounding factors that are going on here.
Yeah.
Those studies are very difficult.
Yeah. So these are, I've seen maybe 4 or 5 of these trials comparing seed oils to either coconut oil or butter or ghee. And everyone that I remember, this was the result.
It's interesting.
An advantage for seed oils. We can touch on Minnesota if we have time. But another thing that I wanted to talk about, this idea that the omega-6s increases the level of small dense LDL. Right, I think you mentioned that.
Yeah. I've seen that.
Small dense LDL. I've seen a couple of trials also comparing, again, isocalorically, omega-6 seed oils. I think it was sunflower seed oil compared to a more saturated fat rich food like butter, for example. The sunflower seed oil tends to reduce all sizes of LDL, large, small, intermediate LDL sizes. So that's what I've seen in terms of that evidence. I haven't seen a study where seed oils raised LDL. But I think another thing that to bear in mind is that for most Americans, for most Westerners, seed oils are not being consumed pouring some canola oil in a salad, right? It's included in ultra-processed junky foods.
That's right.
Absolutely crucial. Again, going back to this distinction of the quality of the foods, absolutely crucial. If you're getting your seed oils from eating potato chips or whatever it is, donuts that happen to have some seed oil in there, then I would expect weight gain, visceral fat to go up, lipoproteins to get worse. Yes.
And that's why those studies are so hard to interpret, because, what else is happening in that cohort of patients? Or is it only the difference in omega-6 intake only? Or how is that omega-6 getting in? So you got to really do a deep dive into that. And it gets very complicated to really see that, okay, was it the omega-6 in the donut? Or is it the processed flour? Or is it the frying process? Is it the ages that was there? What are the factors going on there? So you lump it all together and you have, omega-6 is no good for you.
This is why I find these trials helpful. And I'm not saying that's all the evidence. I mean, real world evidence absolutely counts, and how people find these foods and how they cook them and in what context, all of this matters. But it's precisely for this reason that I find these studies informative, is because they allow us to separate these factors. Is it seed oils that are damaging, or is it the fact that seed oils usually come in these ultra-processed foods? And so the two things track together. And the evidence that I've seen consistently points to this latter case, that seed oils are a tracking a junk diet, an unhealthy diet.
Yeah, but accompanying them.
Yeah, when they're used.
You are so right. You are so right about that. You are so right. You're so right about that. That's why all this is going to take more teasing out, more time. In the meantime, I just tell people, look, eat real food. Eat real food. Don't put anything that's made in a factory. Because if you look at an oil processing plant, a seed plant, it looks like something out of Saudi Arabia. It looks like a oil refinery itself, because in a form it is. I just feel like having a more natural diet without relying on factory-made foods is going to serve my patients well. And I'm tracking the data. So just like how I have evolved in what I've done, I may come out in the future and say that omega-6 may not be as bad. I'm not sure yet. Yeah.
I appreciate the openness. I think that's a sign of quality, that we are open to hearing arguments. And I really appreciate, by the way, your time. And this is so valuable for people to see, so crucial, because I try to have these conversations and a lot of people don't want to have them. They don't want to talk to anyone where they perceive there's a difference of views, or people have seen different evidence. That's so strange to me. This is what science is all about. Let's compare the evidence we've seen and
we
talk.
We have to. And based on that evidence, we change. So we've done that, and we have to continue to do that. No, hats off. And we have to have people like you who's going to be looking at all these studies and reminding us that, hey, in this study, it was like this or whatever. We have to have it. And I think that this is going to be a great, maybe we can revisit the same area in a couple of years. Yeah.
I'd love to do this again in the future.
Fantastic.
If you want. I think you still have some time, right? Bree told me until another hour or so.
Yeah. Okay. What time is it? We have good time.
I have lots of questions. If you tell me when you have to go, but I have lots of questions because I love this stuff. I find it all fascinating. Okay, the question of the particle size. This is something that I've found fascinating. I've tried to read everything I could on the particle size, the small LDL, the large LDLs. I've had a number of lipidologists on who spent their careers studying the particle size and heart disease risk. I've had Ron Krauss, I've had Cromwell, I've had Dayspring, all these people. Yeah. From what I've seen, this is a summation of what I've seen and what I've heard from these experts. Everybody agrees the small LDLs are problematic when too high. Some of them believe that there's a difference, that the small LDLs are more atherogenic. Dr. Ron Krauss believes that there is a difference. Several of the lipidologists believe that it's about a wash, that they're roughly equally harmful, the large and the small LDLs. I believe this is the majority opinion in lipidology, but let's not quibble with statistics. Let's just say some people are on one side, some people are on the other. And most of the studies that I've seen, when they account for the number of particles, right, which is crucial, they find both particle sizes to be potentially harmful. The small LDLs and the large LDLs, if they're too high, both are linked to risk of heart disease.
Correct. You're absolutely right. If you want to look at one number that is probably the most predictive of future cardiovascular event rates and atherogenesis in general, the total number of particles is very important. So you want to get the total number of particles down, and it's not an easy thing to do. I've found it's difficult to do that, but I have been able to improve particle sizes. And I do that by chasing inflammation and all these risk factors that we really talked about. Are they all atherogenic, large and small? I'm not 100% sure, because there are so many patients that come to me. Okay, so let me tell you, familial hyperlipidemia. They come to me with a LDL of 350, 300, and I do a coronary calcium score and it's 0. And I said, now how did he escape all this? But when they develop metabolic disease, now they get heart disease. So the ones who have familial hyperlipidemia who also develop a metabolic disease, some form of metabolic disease, whether it's prediabetes, obesity, fatty liver, gut problems, I find that they are the ones who then now get coronary artery disease and coronary calcification. That's one thing. The second thing is that recent studies, and I don't have the study in front of me, but it's the Scottish study, it showed that when we looked at event rates in cardiac patients, it was small dense LDL that was more predictive. All were predictive, but small dense were the most predictive of who's actually going to get an adverse outcome. So right now, I try to bring the numbers down. I also try to bring the particle sizes bigger by chasing inflammation. So this is important. There are other compounding factors which which we are still learning, because there may be other associations with the small dense LDL versus large ones. There may be other things going on which we don't know about yet. So it's a growing area of concern. There's a lot of debate amongst people. I'm more pragmatic. I don't chase numbers so much. I chase physiology. I chase abnormalities in your body that shouldn't be there, like the fatty liver, inflammatory markers. Let's get all those down. Let's get rid of the fatty liver. Let's get rid of your inflammation, the markers. I want to see your interleukin-6 levels coming down. I want to make sure that your CRPs are coming down. I want to make sure that your small dense LDL particles become pattern A. And I've been able to do that. Make them go to pattern A. And I've been able to do that. And that has been definitely shown to improve outcomes as well. So, yeah. So there's a lot of debate. Every cardiology conference I go to, it's all about this. Yeah.
Yeah. I think most of those changes are unambiguously beneficial. A lot of these things, reducing visceral fat, reducing inflammation, reducing blood pressure. I mean, these things are clearly advantageous. And I think even if you reduce someone's small dense LDL number, in most people, that's going to reduce the total number of particles. So it's probably going to be a net positive.
Yes.
I think this becomes a concern when people take the corollary, when they say, oh, the small dense are really bad. Well, I have sky high ApoB, but they're fluffy, so I'm safe. That the evidence that I've seen is consistently against that. But
that's true. I have to agree with you, because the particle size and the ApoB, if you still have a large, so your particle size may be, let's say, 221 angstroms, and you're going to say, oh, that's not too bad, but you have a lot of it. That's not good. You are going to run into problems. So I agree. You got to look at the whole picture, and don't become myopic just on this area only. Yeah, no, absolutely right. Absolutely right.
There's virtually 100% agreement, because that's also Dr. Ron Krause's position, that the small LDLs might be nastier particle for particle, but you don't want to have your large LDL sky high either. So there's agreement on most of it across the specialist community, as far as in my experience. Other things that would be, okay, we can touch on the Minnesota trial real quick, just because it's such a common question, and I've looked into it. So I don't know what your recollection is of the trial, but there was a massive trial. It was 9,000 people, and they planned to follow them for about 4 years, give or take, because you can explain this better than I can. You need statistical power to detect a difference in heart attacks, right? You can't detect it over a couple of weeks or something like that. And then what happened, and I don't know if you have a different, if you've seen different information on this, but what happened was they lost 75%, I believe it's 75 of their participants during the first year. And overall in the trial, they lost 83% of their participants. And so they didn't have statistical power to detect anything. And in fact, every outcome was no statistical significance between the two groups. I don't think there was a single thing that was significantly different between the two. I know that people talk about the mortality. I think it's a trend. Like if you look at the graph, it looks like the mortality might be trending. Again, with this attrition rate, when you lose 83% of your participants, really hard to interpret. And then there's additional questions about the trans fats, because back then in the intervention group, they were reducing saturated fat but increasing trans fats. So there's a whole debate about that. But in my opinion, the Minnesota trial is almost impossible to get anything firm out of, just because of these issues. So I just think it's interesting to,
It is true. That study is clouded with a lot of controversy. A lot of that data didn't come out for years later. So it took so many years, and more, as you said, you take statistical analysis and just work on it. So it was suggestive though, but it's not definitive. I don't go by any one particular study, but it's one of some that I looked at. and to try to, again, you see, you have a hypothesis that, okay, I don't like artificial things. I don't like processed foods. I don't like anything made in a factory. Where can I find data to support me? You see? So these are the biases that we all have. And am I biased? Of course I'm biased, because I want all natural things only, natural foods only, as much as possible. So I go out looking for those kinds of data. And there's a couple of other studies, which I don't have with me, but I wish one day we can, and we can have a special session just on this.
Yeah.
I'd love to discuss it with you in more detail. But
Yeah.
in general, yeah, that was a study that kind of perked my interest, and I looked at it, and then the details are more important, as you pointed out. When you have such a high attrition rate, you lose a lot of statistical power. Yeah, and there's going to be a lot of bias.
Yeah.
Yeah.
I have one more question about fruit,
Sure.
because this is something that was that you brought up in one of your recent podcasts and got a lot of attention. But I want people that are listening to this, and I think this is going to get a lot of interesting comments, and this is going to be very stimulating. And I want people to understand that we agree on the vast majority of things. I think we agree on the fundamentals. There might be some difference in terms of this study, that study, but the fundamentals.
Yeah.
A lot of visceral fat is not good news. A lot of these atherogenic particles is not good news. High blood pressure is not good news. Insulin resistance is not good news. I mean, I think we're on the same page on the vast majority of things. A diet with fiber is a good idea. A diet avoiding ultra-processed foods in excess is a good idea. A diet avoiding refined carbohydrates in a large amount is a good idea. I think all of this is there's so much evidence for these things. Yeah. So my question about the fiber is, you brought up this idea that I was very surprised to hear this
about fruit.
Yeah. You said our overconsumption of fruit is a factor contributing to heart disease, diabetes, and fatty liver.
Our overconsumption of fruit is another factor that is contributing to coronary artery disease and diabetes and fatty liver.
Yeah. No, it's absolutely true. So when you're on this Western diet, which is already overwhelmed with carbohydrates, which already has all these associated metabolic abnormalities, and now you're throwing lots of fruit as a health food, it can compound the problem. Yes, it's going to give you some fiber. And as long as the fruit is whole, I generally like whole food, but that's not how a lot of people consume fruit. They juice it, and then they cut the fiber into slitherings in the machine as well. And they consume a whole bunch of it all at one time. No good. Real food, I can't eat 2 apples and 2 oranges all at one time, but they can put it into a juicer and I'm done. So I don't like the way that fruit is being consumed. Number 2 is, if you already have metabolic disease, if you already have a fatty liver, if you already have prediabetes, then I think that the fructose is not good for you, because the fructose is a molecule that will put you into a fatty liver state. It could produce more fatty liver. We know that. And that's why I do tell my patients who have a fatty liver that, hey, listen, I know fruits are good for you in general. Yes, they are. But for you should not be eating fruit right now until your liver is better. And for the general population who are eating the Western diet, fruit is not good for you, because fruit is just going to compound your problem. Now, I know some people say, oh yeah, but that's how they're going to get some of the nutrition, such as some of the vitamin C's and some of the fiber. Yes, it's true. But at the same time, it's going to drive their obesity. It's going to definitely drive their fatty liver, and it will drive their prediabetes as well. So I think we have to, again, take the individual patient. Generally speaking, yes, I rather you eat real food, eat real vegetables. Fructose and fruit are supposed to be consumed at the time of the fall, so you get ready for weight gain, fat gain, so that you can get through winter. And that's how it is in nature. And I don't think we should be consuming so much fruit throughout the year. The next thing is, fruit should be consumed according to the seasons only, but we don't do that. We eat fruits at all odd times of the year. And do I have studies to show that that's not good for you? Not really. But there are minor small studies that show that fruit eaten out of season can cause more hyperinsulinemia and more obesity. But again, we need more detailed studies on those. So I think that fruit Fruit and vegetables should not be lumped together. Vegetables are good for you. Vegetables are great for you. And the fruits should be consumed seasonally in small quantities, especially if it's combined with the Western diet that we have today.
Mm.
And look, if we look at the population, obesity now is just hit over 50%. Insulin resistance is a huge problem. And we know that a huge population has fatty liver. Then excessive fructose is out of the question. You should not be consuming so much of that. Yeah. And let's work on other ways now. Fix yourself. Then you can reward yourself with some fruit. I have seen in my own patients that when they cut out that night fruit, eating fruit at night, where they would sit down and consume a whole bunch of grapes or a whole couple of bananas and an apple, when they just cut that out, right there, I'm noticing that the patients tell me they sleep better, they start losing weight as well. And the H1Cs come down, insulin levels have come down. So it's just sensible. Don't eat the Western diet and have high fruit consumption. Yeah.
From what I've seen, the average American eats about 2 or 3 times less than the fruit that's recommended. So the trend is to massively underconsume whole fruit, right? And we're not talking about fruit with all kinds of other stuff or refined sugar added. We're talking about an apple or some strawberries. Or in general, people massively underconsume it, at least as far as the guidelines. With regards to the fructose, I just wanted to introduce this note of nuance as well, because I think there's a trend throughout our discussion of, okay, carbs are a problem, depends on the type of carbs. Fats are a problem, depends on the type of fats. Like there's always this element of the quality and the context. I find the exact same thing with fructose. There's definitely evidence pointing to concerns of fructose, but it's purified fructose. It's fructose given in soda, for example, or purified and given to people or given to animals in some experiments. But when we look at the data on fruit, and this includes people with diabetes, I generally see between no difference and benefit. I can't find a study showing harm of fruit when calories are accounted for, right? I agree with you. If someone is consuming already 4,000 calories a day and they add 500 calories of fruit, that might not be great. But when calories are accounted for, and in general, fruit is going to replace more refined sugars, I can't find a study that points to harm.
And I agree with that if your diet is good otherwise, and even though you're a diabetic, but your diet is good otherwise, then you can have some fruit. But the patients that come to me are patients with severe coronary artery disease. They have severe coronary calcification. They have a lot of visceral fat. They're obese. They are metabolically so deranged. Their guts are because fructose also causes more leaky gut. So those patients, I tell them clearly, you need to cut out the fruit, and they're shocked to hear that. But when they do that, they do feel better and they do get better. I think that we're looking at different extremes of the population. So this population, yes, they must stay away from fructose in the form of fruit, even though that same fruit is going to be of benefit in another cohort of patients. So we need to really look at the overall. Who is consuming this fruit is the question. Who is consuming fruit is the question, and that's what's going to tell you whether it's okay for that person to be on it or not. So my patients that come in to see me, majority of them I tell them no, because they are all body mass index 30 or more, and they're coming to evaluate their cardiac situation. So there you go. So again, there's a nuance on everything. So I have to agree, because look, fruit is nutrient dense. It is true. And it has a lot of phytonutrients in it. And I told you, I love different colors. I put blueberries and I put raspberries and that in my kefir every morning, and that's fine. But those that are very obese patients who have a lot of metabolic disease, I tell them no, cut out the berries as well for now. Just stay away from the berries. Just do the kefir with the inulin alone, and then later on when they're better, I'll reintroduce some of the healthy fruits, because now those fruits will be part of the healthy diet.
I wonder if you're seeing the improvements, and this is just a suggestion or a thought, I could be wrong. I wonder if you're seeing the improvements because of all the other changes, and the removal of the fruit is maybe having no effect, or who knows. The reason I ask is that when we look at populations with heart disease, specifically a population that's at risk of heart disease, and you put them on a Mediterranean diet, or you put them on a plant-rich diet with fruit. A number of trials have done this, and we consistently see benefit. And so, again, I don't see a compelling argument for removing fruit. But I agree with you that it's one component of diet. If you remove fruit and you add, for example, some non-starchy vegetables, I don't think that's a problem. It's probably fine. So I don't think you need to have a boatload of fruit in your diet to be healthy. I just don't see a compelling argument to be scared of fruit. And because most Americans massively underconsume it, I worry that when we say something about fruit being a concern, our overconsumption of fruit is a factor contributing to heart disease, diabetes, and fatty liver, that we're going to scare people from eating a food that is overwhelmingly beneficial.
Yeah, it's you're absolutely right. A broad statement like that can be misconstrued because fruit can be a very valuable source, especially of vitamins, and especially vitamin C, for example, and other micronutrients. So, no, I do agree with you. I think, again, it's in the context of who is consuming it and how they're consuming it. So how is also very important.
Yeah.
So I think that, again, you see, it comes down to people like us who have to be a little more careful about how we get a message across to people, because it gets a little tricky. What we're saying can be misconstrued. Who we talk about? Which population are you talking about? The sickest of the sickest. Okay, fine. That's a different story. Let's get them better, and then we can put them back on a normal diet. I have fruit. I have very little fruit in the sense that I don't go out and drink juices, and I only have a few fruits, a few pieces a day, and I'm done. That's it. Yeah. And because I have a healthy diet otherwise. Yeah.
Right. And I really appreciate this conversation, because I think this has been very productive and I think very helpful for people, as my guess. Sometimes I'm surprised in the comments by people's takeaways, but I think people will be very pleased with this, because I think we were able to get down a little bit of the reasons behind views and clarify a lot of things. And one note that I see from my viewers is a lot of times confusion and frustration. Everybody's saying something different on the internet. I don't know what to believe. Nobody agrees. And I find that when we have these conversations and we get down to why do we believe X, we find that there's overwhelming agreement on the fundamentals. And then the differences are sometimes details.
I agree. I love it. I love it. I love what you're saying.
We really appreciate it. Anything else that we haven't talked about that you want to leave viewers with?
Well, yes. And again, it comes down to cardiology. And maybe this is an area that I am looking into, which is stress. And stress is a huge, huge topic, and it's too open, it's too broad, it's too wishy-washy. But what are we really talking about? And I just want to throw in some things that I have learned in cardiology, because ultimately, almost everything that I'm trying to say is out of what I have actually learned in my practice. Medicine is the practice of medicine, right? And I got to truly say that I've been blessed that I'm practicing medicine, because when you practice something, you get better at it, and you change and you fall and you get up and all this stuff. But one thing I have noticed about stress and sleep, and so sleep is very important, but just stress in and of itself, that in electrophysiology in the heart, you have the parasympathetic and the sympathetic system. And I've known and I've seen that the more stressed out a patient is in their life, I've noticed that they get more arrhythmias, more high blood pressure. And if they have, for example, atrial fibrillation, or if they're having multiple premature ventricular contractions, they get them much more often. And we would like to divorce the PVCs and the atrial arrhythmias from the mental state, but I've not been able to do that. There is a correlation. It's not just your anatomy and your physiology, and your mental state does affect your arrhythmias. And I have therefore done some work with parasympathetic, building more parasympathetic build up in your body. And what does that really mean? Parasympathetic is when you are resting and relaxing. That means you underwent something stressful. Let's say you went to work, but when you come back, now you're not stressed. You should be completely relaxed. But if you're not and you're still carrying what happened during the daytime onward, you'll never get a chance to have the parasympathetic. And you need parasympathetic to restore, relax, reward yourself, and your chemistry changes. And we know from animal studies and other studies that your chemistry does change. We know, for example, that your platelet reactivity changes, your catecholamine levels changes, your vasoconstriction changes. Yeah, there's so many parameters that we can measure that are correlated to stress. For example, I'll give you a simple example. If you take an arterial line and put it in the radial artery, and you're constantly taking blood out and you're looking at platelet reactivity through a refractometer, and let's say that the person is a medical student and is flipping through the questions that he knows and he's able to answer them, the platelets are fine and not a problem. But the moment he comes to a question that is extremely tricky, very difficult for him to understand, but he's under pressure, the platelets start reacting and they become sticky. And you start seeing clumping of these platelets and they start degranulating. So your mental state somehow metabolized itself to the point where your platelets are more reactive. Why is this important for me? Because most heart attacks occur on a Monday morning, and they tend to occur in the first part of the morning. And you can say that, okay, it's cortisol. It's not cortisol, because we all get a morning cortisol rise. That doesn't mean that that's the cause of it. We do know that severe stress, bereavement also precipitates plaque rupture. But not only that, a big blood clot formation. There is an effect of your parasympathetic system or lack of parasympathetic. And when I talk to my patients about how to improve their lives, I also talk to them about stress management and how they need to find ways to turn that monkey off in the brain and go into a state of restfulness, where you're in charge of what thoughts you're going to entertain, so you don't become the slave and thereby, a stressed out person because you have no control, because you keep rethinking and reminiscing on your past or worried about the future and how you're not able to live free in this moment. So I do teach my patients how to do mindfulness, meditation, how to quieten the mind. And what effects have I seen? There are studies to show that these are helpful in patients. But in my own observations, blood pressures come down, blood sugar controls better. But all this is fine. But I also notice that these patients have more willpower. That those who are able to de-stress themselves have more willpower to make the changes they need to make. Because everything I talked about today and you talked about requires willpower on your part. That, okay, I am not going to keep nibbling every 2 hours. I'm not going to walk past those donuts without picking 2 of them up. I am going to have willpower to go out and do some form of exercise. And I'm going to have willpower to go out and shop for the right things. How do you get willpower? So the patients often tell me, I know what to do, doc. I know I need to lose weight. I know I need to fast. I know I need to cut my habits of my eating and this and that. And I know I need to go to the gym or go for a walk around the block after my food. But how do I do it? I just can't do it. Now, when I hear that, then I say, well, what am I going to do? I'm doing everything possible that I can do. And now I'm saying I have another tool. I'm going to teach you how to control your thoughts and come back to what you want to do. And that ability to bring your attention rather, from a thought and come back to the tip of your nose, for example, and then another thought comes and bring it back again here. And do that type of exercise where you changing the attention and putting it on what you want or taking it away from what you don't want it to and put it on something. I find that this has really helped hundreds, maybe thousands of patients. where they now feel that they are in control. Otherwise, they felt that they were a slave to the monkey inside because thoughts keep coming all the time. And this does translate to better behavior, more adherence to my lifestyle that I want them to do, and a more pleasant lifestyle. They feel better as well. So I'm investigating this, and I did make one video, and maybe one day we'll talk about, which is how to hack your vagus nerve. And that's on YouTube, said how to hack your vagus nerve. And has this helped patients? Yes, it has. Do I have a double-blind study? No, I don't. But it makes sense, again, that, look, everything we talked about is trying to go back to nature. Well, that's how nature was. You'd run away from the tiger, then hide behind the tree. And then once the tiger's gone, now you're back to your normal self. You trot out there and start walking all your way again. This is how we're supposed to be, not be stressed out all the time. And I think that the fear, the existential threat that we now have in modern society, the existential threat, everything becomes an existential threat, a threat to your existence, is generating a physiology in your body that is very detrimental. This way we're living, not just physically, but mentally also, the way we're living is causing too much stress on the patients. And sometimes it takes a lot of sitting down and just telling the patients that, look, you need to make these changes in how you think also, because your thoughts and your emotions are metabolizing into your body. And that's why all this is happening, and why you have no control. You're lost. You're a boat without a rudder. So I think that this is an area which I'm bringing out for discussion, because it is important for all of us that our quality of life is important. Our stress levels are definitely hurting our health. And to de-stress, what's the definition? My definition is getting very close, because everyone's perception of stress is different. My stress, what I'm pointing out to patients is that, look, you should be in control. Be in the moment. Have control of your thoughts. What you're going to put attention on. Your attention should be focused on what you want it to be on, not become a slave to everything. And when they learn that, when they learn to do that in silence, bringing their attention back to their nose, focusing here, getting it away from them, that ability to bring it back, I find that this really helps a lot of patients feel better and comply with everything that you and I have been talking about today. So I just wanted to throw that out at the end. Yeah.
Love it. And I agree 100%. The importance of peace of mind, this excessive, chronic, constant stress is probably causing all kinds of issues. I agree 100%. Thank you so much again for your time and sharing your views and everything, and the back and forth. I absolutely love it. Where can viewers find you?
Well, I'm on YouTube and also on Aristotle Education. Aristotle Education is a new channel and a new office setting that I've created over here at Cardiovascular Intervention side. And what it does, it looks at patients in a holistic fashion. So I spend about 2 hours with the patient. And this is in Aristotle Education. So if they Google that, they'll find Aristotle Education. I'm there as well. Then I do my regular cardiology practice, which is cardiovascular interventions, where I see day-to-day patients. I do surgery every day. I'm in the lab every day. This is my day-to-day stuff that I do. But my passion really is that we really have to make a dent on prevention, because I don't want you to see you on my table. So there you go. Thank you again so much. I really appreciate this. I had a great time.
Yeah, no, I absolutely loved it. Out of all these conversations that I've had, it was one of the probably the most productive because we really got down to the nitty gritty, and I think it's going to be really helpful for people. And I really appreciate your time.